Hey, all you cool cats and kittens. Want to talk to you a little bit about how the actual function of breathing works. So, to take a breath in, your diaphragm is going to contract. So, the diaphragm here across the bottom of the pleural cavity, it's going to contract, which makes it get shorter. This process is known as ventilation. Again, that's the process of moving air in or out of the lungs. So the diaphragm contracts, moves down, that creates a vacuum. And so air is going to rush in to fill the vacuum from the outside down the trachea, down the bronchial tree, eventually filling up the alveoli. The intercostals, which are the muscles between the ribs, can contract even more, further bringing your ribs up and away from your midline, creating a bigger space, using the forces of vacuum and a pressure differential to bring air from the external environment into your lungs. The membranes of all the tissues within the lungs are going to move. There is a surfactant that's produced within the alveoli that keeps them from collapsing and sticking together. If you've ever had a plastic bag that was wet on the inside, you know that bag likes to stay collapsed. So surfactant is going to keep the alveoli from sticking together so that when air does rush in, they will fill easily and completely. And then if you need to keep drawing air in addition to the diaphragm and the intercostals, pectoralis minors, sternocleidomastoid can continue to contract. And basically what they will do is continue to expand the rib cage even more. So if you see, especially somebody's neck muscles being used with each breath, you know that they're working pretty hard to breathe. Now, if they're doing a heavy activity and exerting themselves, that's completely normal. If somebody's sitting on the couch or lying in bed suffering from illness and they're using those muscles, that's generally not a good sign, especially in young children. That means that they're really working to breathe. An interesting fact is that surfactant doesn't start being produced until after birth. So that's part of the reason why that very first breath for newborns can be a struggle because their alveoli are collapsed due to the lack of surfactant. I'm going to share this video with you. It talks a little bit about intubation.
You may receive endotracheal intubation and mechanical ventilation if you are in an emergency situation involving severe respiratory problems, or if you are having general anesthesia during a surgical procedure. When you breathe, air moves into your lungs when a muscle called the diaphragm, along with other muscles nearby, contracts and causes the chest cavity to expand. Air is exhaled when these muscles relax, and the lung tissue passively returns to its original size. This is called respiration. During respiration, oxygen in the air passes through your nose or mouth and into your pharynx or throat. It then goes into your trachea or windpipe. Your trachea divides to become the left and right main bronchi, which enter your lungs. Inside your lungs, the main bronchi divide repeatedly and eventually become small tubes called bronchioles. At the end of the bronchioles are tiny air sacs called alveoli. Oxygen in your alveoli is absorbed into nearby blood vessels called capillaries. At the same time, carbon dioxide, a gas in your blood that must be removed, passes into the alveoli and back out through the airways. This process is called gas exchange. If you have severe respiratory problems, the oxygen levels in your blood may drop too low, or the carbon dioxide levels may rise too high. Either of these conditions can result in damage to your vital organs, including your heart and brain. Some conditions that may lead to severe respiratory problems include drowning and obstruction in the trachea, such as a foreign object or tumor. Obstructive pulmonary diseases such as asthma, chronic bronchitis, and emphysema, Diseases such as pneumonia and acute respiratory distress syndrome, or ARDS, severe weakness of the muscles that control breathing, and damage to the bones and tissues of the chest. Under these circumstances, you may need additional oxygen or breathing support through mechanical ventilation. Mechanical ventilation is also used during surgical procedures for delivering anesthetic drugs, preventing the aspiration of stomach contents into the lungs, and closely controlling the levels of oxygen and carbon dioxide in the blood during surgery. Before you are intubated and ventilated for a surgical procedure, an intravenous line or IV will be started, and your doctor will give you medication through your IV to put you to sleep. As the medication takes effect, he or she will place an oxygen mask over your nose and mouth and ask you to breathe deeply, ensuring that you will have a reserve of oxygen in your system prior to the procedure. The first step in mechanical ventilation is called endotracheal intubation. Once you are asleep, your doctor will use an instrument called a laryngoscope to perform the intubation. A laryngoscope, which consists of a handle, light, and dull blade, helps guide the endotracheal tube to its proper position. Your doctor will tilt your head back slightly and insert the laryngoscope through your mouth and down into your throat, taking special care to avoid contact with your teeth. Using the blade, your doctor will gently raise the epiglottis, which is a flap of tissue protecting your larynx. He or she will then advance the tip of the endotracheal tube into the trachea. Once the endotracheal tube is in the trachea, your doctor will inflate a small balloon surrounding the tube to make sure it remains snugly in place. Your doctor will remove the laryngoscope and tape the tube to the corner of your mouth to prevent it from being jostled out of position. Your doctor will check to see that the tube is properly positioned in the lower part of the trachea by inflating your lungs with a special bag and listening for breath sounds on both sides of your chest. If the end of the tube is too low, both lungs will not receive the same amount of air. In some cases, an X-ray is taken immediately after intubation to confirm the tube's placement. Once the endotracheal tube is in the proper position, your doctor will attach it to the mechanical ventilator, a specially designed pump that aids respiration by delivering well-oxygenated air into the lungs and permitting carbon dioxide to escape from the lungs. Levels of oxygen and carbon dioxide will be closely monitored to confirm that the ventilator is working. Once your surgical procedure is complete, your doctor will not remove the endotracheal tube until you are able to safely breathe on your own. He or she will make this determination by measuring how often you take a breath and how much air you breathe in and out with each breath.
Couple things I want to add to that. They showed that they check the endotracheal tube, the ET tube, for placement. Not only do you not want it to go too low, as it showed in the video, well, you want it in the trachea. A common, well, maybe not common, but a potential misstep is you actually intubate the esophagus, in which case neither lung is getting any air. And the other interesting thing is we have really great machines, mechanical ventilators. We've heard a lot about them in the news recently. What we don't have is a way externally to oxygenate blood and remove carbon dioxide the way we do dialysis. So for a patient whose breathing is failing, all we can do is ventilate and hope that the oxygen is able to make it into the bloodstream and carbon dioxide gets out. We rely again on atmospheric pressure differences to get air into the lungs so we can create that vacuum. But if you've got a hole in the pleural cavity, it can mess up that whole process because now you've got a separate pathway for air to come in and equalize the pressure. And now it will be external to the lungs if it's in the cavity and rather than down in the alveolar spaces. And that condition is called a pneumothorax. Pneumothorax, meaning you have air right now. This X-ray showing this is air, not lung. The lung is all this whitish material laying up against the midline. That lung, if you compare it to over here, should be nice and stretched out, but it's not. So something has happened to this patient to cause a pneumothorax. You can have a pneumothorax. You can also have a hemothorax where it fills up with fluid. So I'm not going to play the video, but follow the link down here if you want to see the draining of fluid. So this is really mislabeled. This is going to be a hemothorax. It shows a procedure of draining fluid. That link should take you out to a YouTube video. So that's breathing in. Exhalation is actually a passive process. So where we had to contract muscles to take a breath, you relax, you stop the contractions. And remember, our lungs lifted up and away, as showing you over here. And now just gravity and elastic recoil of all the tissues is going to reduce the size of the pleural cavity and push air out. So exhalation is normally a completely passive, but if you want to go exhale more forcefully, you can then use contraction muscles, especially the abdominal muscles. So if you contract your abdominal muscles, that will continue to force or reduce the size of the pleural cavity, pushing additional air out of your lungs. And I just wanted to offer you a panda here in the middle of our video. Because who doesn't love a panda? And yes, even pandas sneeze. So non-respiratory movements, coughing, sneezing, laughing, crying. So coughing is going to be more to clear some sort of obstruction or irritation in the lower airway. Sneezing is going to be for the upper airway, especially the nasal cavity. Laughing and crying, again, they're using the respiratory system, moving air in and out, but they're not exactly aiding in gas exchange. A hiccup, that's a spasm of the diaphragm. So again, when the diaphragm contracts in a spasm, that's going to bring air in. So if you've never really paid attention, when you hiccup, it's a very quick drawing in of air. What causes them? Unknown. And speaking of unknown, another non-respiratory movement, a yawn. So I really like doing this in front of a group of live students because as soon as I show that picture, I like observing faces and seeing how many in the audience yawned. It's a response called a sympathetic yawn, and scientists and researchers are unsure what the purpose of a sympathetic yawn is. And in fact, there's only hypotheses as to exactly why we yawn. Is it in response to low oxygen levels in the blood, a cooling effect, bringing a large volume of air through the nasal passages, which remember have a lot of surface area? And so we can maybe do some slight cooling. We're not quite sure. A couple quick slides. This is a lab that we're not going to have a chance to do about respiratory air volumes. So just a normal, if you're measuring it, it's called using spirometry. Just like the cardiac cycle is one contraction and one relaxation of all the chambers of the heart, the respiratory cycle includes one inspiration, drawing air in, and one expiration or exhalation, pushing air out. So we have resting tidal volume. That's you sitting right now watching this presentation, just a normal breath in and out. And that a normal adult, that's about half a liter. Then we have what's called reserve volumes, that using additional muscles that I talked about, you can bring extra air in or extra air out. So inhale normally, then without exhaling, pause and inhale some more. And that additional volume we're bringing in is referred to as your reserve inspiratory volume, or some people flip it and say inspiratory reserve. Okay, now on a normal exhale, pause, then continue to exhale a little bit more, and that would be your reserve expiratory volume. Then there's vital capacity, inspiratory capacity, and then functional residual capacity, or as the graph calls it, residual volume. That's the amount of air that will always remain in your lungs. You can never completely empty your air or empty your lungs of air. And then total lung capacity is the complete volume of air that can be in your lungs at any one time. And you can see there's quite a bit of variation, gender, age, body size, athletic conditioning, and then even among athletes, depending on which kind of conditioning. Especially swimmers tend to have large lung capacities, not only because they're holding their breath in the course of their sport, but as they exhale, because they're exhaling into the water, that's additional force and pressure that is forcing their lungs to work even harder, which in turn can help develop a larger lung system. Breathing, as you probably knew, is involuntary, but you can, in a second, take voluntary control of your muscles. It's a very interesting system that we have set up, that it's skeletal muscles. So because they're skeletal muscles, we can control them, but if we stop thinking about it, they will be continue under involuntary control. Where is it coming out of? It's coming out of the pons and the medulla. They work together. And so I don't want to get too much in depth, but just remember that the pons and the medulla work together to control our breathing. Factors that affect our breathing. It's primarily driven by chemistry. So we've got a couple places where chemoreceptors will measure things like carbon dioxide and hydrogen. The primary driver of our breathing are blood CO2. So the primary driver of breathing is actually the amount of carbon dioxide. That's important because it can change your blood pH. You don't want carbon dioxide building up, but when it does, you can quickly detect the change, and that can drive changes in our breathing pattern. And so where does this occur? It occurs right in the medulla oblongata. As opposed to measuring oxygen levels, a secondary factor, that's out in the periphery. So in our carotids and in the aortic arch. So CO2 gets measured right in the medulla oblongata, and so we're much more sensitive to changes in CO2. Additionally, there's the inhalation reflex, and emotions can certainly drive our breathing patterns. All right, a couple notes about breath holding. So voluntary breath holding, eventually you reach the point where you cannot resist taking a breath. And what's driving that? CO2 building up in the blood. Because remember, you're creating CO2 because your cells continue with their cellular respiration, but you're not off-gassing it with exhalation. So it builds up. And notice this says usually happens before O2 levels get too low to support unconsciousness. It is almost impossible to just hold your breath until you pass out. Your involuntary breathing response will kick in. We'll come back to that. The process of hyperventilation, it's rapid and deep breathing. And what you're doing is especially doing forceful exhalations. And so you're getting rid of carbon dioxide much faster than you're bringing in extra oxygen. What can this do? Well, if you've ever been in the pool, you might know this. If you hyperventilate before you try to hold your breath underwater, you can hold the breath. You can hold your breath longer. And again, we'll come back to that on the next slide. But if hyperventilation continues, it can produce symptoms. Starts with numbness and tingling, pins and needles in the lips, in the fingers, and the toes. Continue flushed red cheeks. And often, and also, if a person is hyperventilating, they're probably not going to be speaking in clear, full sentences. Why? Because they're doing rapid, deep breathing. It's hard to talk and do rapid, deep breathing simultaneously. So, should you ever have a friend or somebody you come across that's hyperventilating, how do you fix it? It's kind of a age-old remedy is breathe into a paper bag. The thinking is, again, because what have you done? You have lowered your CO concentration. So we're thinking to fix it, we need to build it back up. So breathe into a paper bag and rebreathe some of your own CO2 and build up the CO2 concentrations. Yeah, it doesn't really work. If it appears to work, it's probably because this is what's really happening. You're getting the person to calm down, gain control of their normal breathing. So in the pre-hospital care, in the EMS world, this is called the talk down technique, because quite often an emotional trigger has gotten somebody hyperventilating in the first place. And so you want to diffuse the emotional response, emotional component of it. But never fear, because if calming the person down does not help restore the normal breathing, they will eventually pass out. And as soon as they pass out, it will fix itself. So never fear. All right, there's a dangerous condition called shallow water blackout. So as it implies, we're talking about going underwater. So first, a normal dive. You're just going to go underwater and hold your breath. So a couple things. So notice we do not want to go into this pink area at the bottom of the graph. So this is where your oxygen levels cannot support consciousness. Stay out of there. But normally the red O2 line, you've got plenty of oxygen during normal breathing. And then the blue CO2, not a problem. And again, and finally, the blue dashed line, if the CO2 crosses that line, it's going to trigger that breathing reflex. We cannot fight it. So notice I go underwater for the dive. Oxygen levels start decreasing. CO2 levels start increasing. But notice we're going to cross the reflexive breathing line without ever getting into the blackout zone. So we take a breath, or it forces us to swim to the surface, and we breathe and restore our oxygen levels and get rid of all that CO2 that we've built up. But now, hypocapnia. That's lower than normal blood CO2 levels, normally caused by hyperventilations. So just like I talked about, you know this if you've ever tried to hold your breath underwater. You do this on purpose. So what does this look like? Here's that hyperventilation. What's that going to do? Look at our starting point for CO2 all of a sudden. We have gotten rid of the extra CO2 without increasing CO2. So we're starting from the same O2 place with a much lower CO2 starting place. So here we go. Now we enter our dive. And just like before, oxygen levels are decreasing. Carbon dioxide levels are increasing. But look what happens. Before we cross the breathing reflex line, we get down into the blackout zone. And so without even feeling the urge to breathe, somebody blacks out. But where are they? Underwater. And suddenly, depending on their natural buoyancy, they could be sitting underwater, blacked out. And usually, as soon as you lose consciousness, your body may or may not try to take a breath. So shallow water blackout leads to drownings every year. You may or may not remember this here in Virginia Beach. It's probably been 2 or 3 years ago now. Some seals were swimming in the pool, and it's unclear, hasn't ever publicly been known, but one of them drowned in the pool. And my speculation is it was probably a shallow water blackout. They were probably doing some breath holding exercises, either as a contest or as a training exercise, trying to increase their stamina. And the person that died probably did hyperventilation prior to a dive and blacked out and drowned. So again, what's the dangers? The body's urgent need to breathe is not triggered before unconsciousness. So what I tell my swimmers and what I advise you guys is, if you want to prolong the dive, sure, take 1 to 2 good forceful exhales to press your CO2 levels a little bit, but don't hyperventilate for 30 seconds. Don't hyperventilate, again, more than 1 or 2 forceful exhalations before you know you're going to dive underwater. That way you can not find yourself in the situation that the graph depicts. All right, so a couple more slides here. So gas exchange occurs across these simple squamous cells. They're referred to as pneumocytes. Oxygen diffuses in the bloodstream, carbon dioxide diffuses out, but other substances can also cross that membrane, such as alcohol. And that's what makes the breathalyzer effective, is alcohol diffuses out of the blood and can be detected in exhalations. Hypoxia, that's a body condition. So if somebody's talking about hypoxia, they're talking about lack of oxygen to tissues and organs, and the one that we're most worried about is the brain. Lots of different causes. Cyanosis, cyan, blue, so a bluish coloring of the skin can be one of the signs of general hypoxia. Asphyxiation is a term where basically that's an interference with somebody's breathing. That's an interference with somebody's ventilation. So, for instance, choking, that is one of the causes of generalized hypoxia. So choking, whether on a foreign object or strangulation, as demonstrated over here by Homer and Bart, leads to asphyxia. Asphyxia leads to hypoxia. Some other problems and disorders of the respiratory system. Cystic fibrosis is a genetic condition. Specifically, it is a problem with a defective ion channel, primarily chloride ions. And what does that cause? It causes thick mucus in the airways. Airways are supposed to have mucus, but the cilia of the pseudostratified epithelia need to be able to move it. So if it gets too thick, it can't be moved. So how do you thin out mucus? Is water. But remembering back to cellular biology, cells can't move water. Water goes where it wants to go. So if you need more water out here in the mucus, how do you do it? You pump ions out. And so the problem to thin out mucus, one of the primary ways is we dump chloride ions into it, and then the water chases the chloride ions, thinning it out. Somebody with cystic fibrosis can't move the chloride ions properly. Mucus builds up, blocks the airways, and interferes with the movement of air in and out primarily, versus gas exchange at the alveoli level. Bronchitis is an inflammation, similar in many ways to cystic fibrosis, but this is due to an inflammation. So it may be short-lived, acute, usually due to an infection, or chronic, meaning lasting a long time and occurs. So it can be caused by infections or irritants. Emphysema, that's a problem with the alveoli. They're damaged, and so you're down surface area, and they lose their elasticity. So remember that they're supposed to swell and stretch with air, and then to exhale, to empty themselves out, there's elastic recoil. But when they're damaged, they don't snap back. So if you think about an elastic, whether it be a rubber band or a waistband on a pair of drawers, when the elastic is worn out, it stays stretched out. It doesn't contract into a tight surface that can't be stretched, it stays stretched out. And so this, not only is it damaged again because we're going to lose surface area, but it can't empty itself of air. And thus people with emphysema have a really hard time exhaling versus inhaling. And then bronchitis and emphysema often get lumped in as COPD, chronic obstructive pulmonary disease. So that's kind of a blanket term, but doctors are either going to look at underlying causes and say it's chronic bronchitis or emphysema, and it just leads to this ongoing problem with the lungs that gets labeled COPD. The most common cause is smoking. I'm going to start this video, but then I'm going to fast forward because the beginning of it talks about wide-ranging health effects of smoking, and I want to focus on the respiratory system effects of smoking once I get my cursor back.
Smoking damages two main parts of your lungs: your airways, also called bronchial tubes, and small air sacs, alveoli. With each breath, air travels down your windpipe, called the trachea, and enters your lungs through your bronchial tubes. Air then moves into thousands of tiny alveoli, where oxygen from the air moves into your bloodstream, and the waste product carbon dioxide moves out of your bloodstream. Tiny hair-like projections, called cilia, line your bronchial tubes and sweep harmful substances out of your lungs. Cigarette smoke irritates the lining of your bronchial tubes, causing them to swell and make mucus. Cigarette smoke also slows the movement of your cilia, causing some of the smoke and mucus to stay in your lungs. While you are sleeping, some of the cilia recover and start pushing more pollutants and mucus out of your lungs. When you wake up, your body attempts to expel this material by coughing repeatedly, a condition known as smoker's cough. Over time, chronic bronchitis develops as your cilia stop working, your airways become clogged with scars and mucus, and breathing becomes difficult. Your lungs are now more vulnerable to further disease. Cigarette smoke also damages your alveoli, making it harder for oxygen and carbon dioxide to exchange with your blood. Over time, so little oxygen can reach your blood that you may develop emphysema, a condition in which you must gasp for every breath and wear an oxygen tube under your nose in order to breathe. Chronic bronchitis and emphysema are collectively called chronic obstructive pulmonary disease, or COPD. COPD is a gradual loss of the ability to breathe, for which there is no cure. Cigarette smoke contains at least 40 cancer-causing substances called carcinogens, including cyanide, formaldehyde, benzene, and ammonia. In your body, healthy cells grow, make new cells, then die. Genetic material inside each cell, called DNA, directs this process. If you smoke, toxic chemicals can damage the DNA in your healthy cells. As a result, your damaged cells create new unhealthy cells, which grow out of control and may spread to other parts of your body. The most common cancer in the world is lung cancer, with over 1 million new cases diagnosed every year. Harmful chemicals in cigarettes can cause cancer in other parts of your body, such as in the blood and bone marrow, mouth, larynx, throat, esophagus, stomach, pancreas, kidney, bladder, uterus, and cervix. Smoking can cause infertility in both men and women. If a woman is pregnant and smokes during pregnancy, she exposes her baby to the cigarette's poisonous chemicals, causing a greater risk of low birth weight, miscarriage, preterm delivery, stillbirth, infant death, and sudden infant death syndrome. Smoking is also dangerous if a mother is breastfeeding. Nicotine passes to the baby through breast milk and can cause restlessness, rapid heartbeat, vomiting, interrupted sleep, or diarrhea. Other health effects of smoking include low bone density and increased risk for hip fracture among women, gum disease, often leading to tooth loss and surgery, immune system dysfunction and delayed wound healing, and sexual impotence in men.
So that video talked about smoking, primarily tobacco. What's not well studied are all the new chemicals abundant in the various vaping products, as well as various states, even though we haven't in Virginia, various states that have legalized marijuana. And so smoking marijuana has not been well studied on what kind of effects that can have on your lungs. And just like the video said, things like COPD and emphysema are incurable. So if we find out in 20 years that vaping or smoking marijuana leads to these things, the people who didn't know aren't going to have a fix at that point. Another disorder associated with the respiratory system, sleep apnea. That's an obstruction usually is the cause. Similar to snoring, but it's more of a complete obstruction where literally a person pauses or slows their breathing during sleep enough that it will wake them. But the problem is then they're going all night without their meaningful sleep. And more research over the recent years has shown how important sleep is to not just brain health, but many facets of our health. So sleep apnea in and of itself isn't going to cause problems outside of waking you up, but then there's the cascade of effects of being chronically underslept. The video mentioned lung cancer, so I'll just keep on moving. Altitude sickness. So when we find ourselves at altitude, a lot of people, it's a little bit of a misconception to say that there is a lower percentage of oxygen. The percentage, 20%, stays the same. It's just less dense. There's not as much of it. So the partial pressures decrease. There's just not as much oxygen available to get into your blood. And so it's often referred to as acute mountain sickness. Can be mild, a headache. And some people also often attribute headaches to dehydration. So should you find yourself at altitude, pay attention because you don't want to dismiss a headache as dehydration when it could be mountain sickness or acute mountain sickness, because it can lead to life-threatening conditions such as pulmonary edema and cerebral edema. We're going to have a altitude sickness article separate from this that has you guys delve into it a little bit more. And the final thing I want to talk to you guys about are bacterial or viral infections. Common cold is an infection of the upper respiratory tract. So I found one source that said there are over 200 viruses that can cause the symptoms, the group of symptoms that are referred to as the common cold. The most common one is what's known as the rhinovirus. And yes, there are multiple coronaviruses that can also cause the common cold as opposed to the current coronavirus that we're seeing now. Influenza, again, is primarily in the upper respiratory tract. As far as the respiratory system's concerned, there can be other systems that are affected. Sometimes influenza can get down into your lungs, and there's only a few known varieties, A, B, and C, that cause influenza. But both the common cold and more likely influenza can lead to a complication known as pneumonia. So what is pneumonia? It's an infection with a virus, bacterium, or fungus. They all do the same thing. The alveoli become inflamed and filled with fluid and or pus. And as it's shown over here, alveoli filled with fluid are not going to be able to do their job. This is supposed to be air and not fluid. We cannot exchange oxygen and carbon dioxide through the fluid. So if you're looking at x-ray, this should be clear like the right-hand side. So this side is good. This side, this is a buildup in fluid. So this right lung, assuming this is the right side on this picture, x-ray, because it's not indicated, has pretty extensive pneumonia. So this person probably is not feeling well and may or may not have some shortness of breath. So the SARS-CoV-2, that is the official name of the virus. The disease, at least as the time of this recording, is being referred to as COVID-19. So the virus, SARS-CoV-2, the disease, COVID-19. It may or may not, when it infects your respiratory tract, it may or may not make it all the way down into the alveolar cells. But if it does, the damage and inflammatory response can lead to pneumonia, the filling of fluids. That's when COVID-19 can turn deadly. Severe cases of pneumonia, whether it's from COVID-19 or other diseases, can lead to ARDS, acute respiratory distress syndrome. It's mentioned in one of the videos earlier, and that's not the only complication that can turn COVID-19 fatal, but what they're finding is that's one of the main complications. And so if you want to know more about what exactly ARDS is, follow the link where the word video is, and a doctor, a pathologist, takes you through some slides of lung tissue that shows ARDS and how basically everything gets thicker and gas exchange slows down. And as I mentioned earlier on the intubation video, we don't have a way to oxygenate blood except through the lungs. So if there's a barrier between the air and the blood in the lungs that's not supposed to be there, that can often lead to bad outcomes. I appreciate everybody watching through this, and hopefully you get a chance to watch us before we have our online meeting, whether with myself or Mr. Bostic. Appreciate any questions, and you guys have a wonderful day until we talk again.